Thank
I'm working all weekend.
I'm watching for a summer. Yeah, my girls had watched it last night. I wanted them to tell them if they had it playing. So I was like, I know that race is now. Thank you.
Hey, y'all, listen up and make me excited about me.
Okay. Alright guys, so I just want to make a quick announcement real quick. As y'all know, the semester is almost over. So we need to talk about 4th level t-shirts. The first day of class, you know, when we go to General Assembly, we'll all have our matching 4th level t-shirts on, but we actually have to decide on a design. So you guys take this next week and think about a design, make a design. I know Shannon did an awesome job helping design this t-shirt. If anybody has any ideas, if you find something online that you like, something, you know, NCLEX, graduation, something about like how hard that we have worked to graduate from this program. So take this next week that we're off, think about a design, send it to me or Kaya, and then we're going to put them all together and let you guys vote on which one we like the best. And then when it gets closer to the end, we'll take up money. I'm going to pass this around. This has where you guys can put your sizes on it, so we'll know how many t-shirts we need, what size we need to get them in, and then we're working on finding places in the area that do t-shirts. If you know a place that makes t-shirts, just find out.
Don't you do something?
I have a t-shirt guy.
Oh, cool. Okay, that's awesome. So we just need to figure out, like, find out a price and let everybody know how much they're going to be, and then at the end, we can take up the money before we go for Christmas break, and then we'll get them made over Christmas break, and then as soon as they come in, I mean, I'll drive to Hattiesburg. I live in Picayune, so all you Picayune people can just come by my house, or I'll come to you, whatever. Or I'll come to Hattiesburg and we can meet somewhere and let y'all pick them up so that everybody can have their shirt on the first day of class. Okay?
If you will email me the design, I'll email it to the t-shirt guy, and it's usually $10 to $12 a shirt.
Okay. Does that sound good to y'all? $10 to $12 for a shirt? Okay. So I really, really, really want everybody to have a shirt. It's going to look funny if we all go in there and like 3 people don't have the shirt. So.
And if you have a hard time getting too hard to get your shirt, a lot of times they'll bring the shirts, have people's names on them. You wear whatever y'all decide. So you wear your blue jeans and then just like a normal shirt, and then you change into them, or a lot of people just slip it on over what they already have on. That will save you some time too.
I just want to wash my shirt before I wear it. So. But it's up to y'all. I mean, if y'all want to wait till the first day to grab your t-shirt, that's fine too, whatever. But I'm going to pass this around. Y'all please put y'all's size on it so we'll know how many we need. I'm going to start with you. Of course you do. That's why I'm saying it.
Okay, y'all listen up. We're going to talk about fractures. So everybody pretty much knows what a fracture is, but we're going to talk about how to treat the fracture. So with children, they can withstand a lot of pressure on their bones. Like I said before, they bend instead of break. So because they bend before they break, what kind of fracture do they have? Green stick is typical. That does not mean that the child cannot have a different type of fracture. If the infant is rolling off of the changing table, what is your initial reaction going to be when they start to roll off? You're going to grab whatever you can grab a hold of. What are they going to keep on doing? Rolling. So you can have a spiral fracture. However, if mama accidentally breaks baby's leg, what's her reaction going to be? She's going to be running baby into the emergency room. She's going to be crying. she's going to feel terrible, isn't she? If that's not an accidental fracture, you typically have a different kind of reaction from the parents. Not always, but most of the time they're a little blasé about the fracture. So if there is something other than a green stick, and it is in especially if it is in a long bone, because what's going to break easier, small bones or long bones? The long bones are going to be more difficult to break. So if you have something other than a green stick, especially in a long bone, it's going to throw up a red flag. But what if it is an accidental break? What's going to be behind that accidental break? An explanation, a story. And what's that story going to match?
Every single time.
The type of fracture that is present. If the story doesn't match up, if there's a spiral fracture of a long bone and they say that the baby fell off the back of the couch, does that really match a spiral fracture of the femur? No. But if they say the baby was rolling off of the changing table and I reached out and I just grabbed a hold of something and I heard this snap, is that going to match? Yeah, so the story has to match the injury. If we have an injury to a growth plate, what could that eventually lead to with that extremity? We could have a length discrepancy. So someone asked this morning to explain the length discrepancy, and the length discrepancy in the legs typically means that there's something going wrong with the hip. Something has happened to the hip, and the head of the femur is not sitting in the hip socket appropriately, and it's causing one leg to be shorter than the other. However, if I have an injury to my growth plate, I could have a length discrepancy as a residual effect of my injury. Does that make sense? It could also be a length discrepancy of my arm. If I have a fracture, let's say, to the head of my humerus, I could have a length discrepancy as that growth plate was affected. I could have one arm shorter than the other. Does that make sense? It could be a result of a tumor or abuse. Why would a tumor affect? Why would I get a fracture from a tumor? The tumor is growing inside that bone and causing it to be weak. So if you do have multiple fractures, they may look. The child has multiple fractures. They may look into whether or not there is bone disease going on as well. So who's had a fracture before? Does it swell? The swelling, whenever there's a fracture, the blood goes to that area to try to repair that area. So there's tissue damage around the bone as well. So inflammation sets in. That inflammation is, yes?
If you're talking about the humor and the bone causing a fracture, you see that on the x-ray, right?
Yeah, usually. But if the child keeps having multiple fractures, they might look into something going on with the bone. But yeah, you could see, if it was a large tumor, you could see it, but they may keep looking into it. I'm not going to ask you a question about that. Inflammation. So inflammation sets in. That inflammation is one of the primary causes of complications post-fracture. So when the inflammation sets in, there is a connective tissue that sits on top of your muscle called fascia. And that fascia is not stretchy like your skin is. So it will stretch to some degree, but then if that inflammation still continues and that fascia does not have the ability to stretch with the inflammation, then that is when we get compartment syndrome. So what is compartment syndrome? What are we looking at the distal extremity? decrease in circulation. So our fascia becomes a tourniquet effect, and it causes decreased circulation to the extremity, to the distal extremity. Are y'all with me? So if inflammation is one of the primary causes, what are some interventions we can do to decrease inflammation? What would you say?
NSAIDs.
NSAIDs, we can give them some anti-inflammatory medicine. Does it need to be low or high? Somebody said it. High. We want to elevate it. How are we going to elevate it? Do we tell the baby to hold their hand up? Prop it up on pillows. We're going to have them rest it and prop it up on pillows. What would ice do to my extremity? It decreases inflammation, but what else does it cause? Vasoconstriction. So you want to make sure that the physician knows you're putting ice on it, and then do you put the ice on it and leave it and never come back and look at it? What do you do to it? You put it on there and what? Take it off and check it. So you're going to take the ice off. We typically say 15 minutes on, 15 minutes off. Because if you leave it on there too long, it can cause impairment to the periphery as well. Do you have to have permission to prop the hand up? You just go ahead and you just do it. But I would ask permission to put the ice on the extremity due to the fact that it causes vasoconstriction. What's an open fracture? The bone has poked through the skin. So what would a closed one be? The skin's intact. So we talk about open and closed in that case, and then there's open and closed, reduction and fixation. What's reduction? If I reduce the fracture, what does that mean? The bone is dislocated, and we're going to put it back in alignment. Now, if I've moved it back into alignment, what do I have to do at that point? Hold it in that position, right? Because if we don't hold it in the position he puts it, what's going to happen to that bone? It's going to slip back out of position, right? So if he has to open up to internally reduce, so if I have to internally reduce it, what's he going to do? Surgery. He's going to surgically open the skin and manually put that bone into place. So while he's in there, what's he going to do? How's he going to fixate it? He's going to use pins, screws, rods, wire. You can see the wire wrapped around the extremity. And then he's going to close it back up. So if he's going to do one open, he's probably going to do the other one open as well. So then you have a wound to worry about afterwards, right? If he's fixated it internally, can the child just go about their business? Is it fixed?
No,
they still have to they're going to have some type of immobilization device on the outside. It could be a cast, it may be a splint. If it's a leg, they may have one of those boots on. Just because they have a boot on, does that mean he wants them putting weight on their extremity? What's that boot there for? Keep it still and immobilized. So you got to ask, what kind of limitations do you want with this extremity? If you internally fixate the bone, they have to have something on the outside of it as well to stabilize it until the bone heals. So what would a closed reduction be? He grabs one end, and pops it back into place. If you know he's about to externally reduce it, what do you need to be getting? And what else kind of medication? Some sedative. You're going to get some type of sedative. They're going to put them down quick, and then you're going to recover them. So you have to be prepared not just to help him reduce it, but you got to be getting the medicine ready. And then you have to be prepared to watch that child or that patient afterwards. Because if you've just given me sedation, what do I need in my nose? Oxygen. What do I need on my finger? Pulse ox. And you got to make sure that you're watching me for what? My respiratory effort. Because you can put me down so far that I'm going to end up purchasing what kind of tube. endotracheal tube. So you got to make sure that the baby is respiratorily able to handle the reduction as well. So he's just externally reduced it. He's popped it back into place. What does he need to have ready, available to put on the outside of it? Some type of splint. Do we just grab plaster cast and start wrapping it up? No, somebody is trained to do that and they'll come in, but you got to have some type of immobilization device on the outside to hold that bone in place. A cast or a splint is a type of external fixator, but we do not refer to it as an external fixator. You do not, if the baby had a cast on, you don't say they have a plaster external fixator. What's an external fixator? Rods and pins, and it looks like that halo traction, except it's wrapping around the extremity. That's an external fixator. But a cast is a type of external fixation in the fact that it fixates the bone where he puts it, and it's on the outside of the body. Does that make sense? Okay. I have heard what spasming? Is the bone spasming? The muscles around it are spasming. I have heard that the spasms hurt worse than the actual fracture of the bone. So you may be give a medication for the spasms. It may not hurt all super bad all the time if they keep it still, but as long as that bone is out of alignment, those muscles are going to spasm because they're not used to the bone being in that position. Once I've been told, once again, I've never had a broken bone, but patients have said, and physicians have said, once they get it into alignment, the spasms will decrease. They may not completely go away, but they'll decrease. I have never experienced a spasm, but the patients seem to be in excruciating pain when the spasm happens.
It feels like a heartbeat, kind of like
Yeah.
in your hand or like in your wrist or wherever it's broken.
Ugh, it just makes my bone pain just makes my belly hurt. What would crepitus be?
Rice Krispies.
It feels crunchy under your fingers, and it's gross. So if you put your hand on it and the person tries to move their extremity and it feels crunchy, it's broken. What do you think my primary intervention? Suspect that my patient has a fracture. What is my primary intervention for that extremity?
Immobilizing in that position.
Immobilize it in the position if possible. Now, if my mamaw is laying on the floor, she's fallen and she's broken her hip and she's having respiratory distress because she was going to ambulate to the potty without her oxygen on, and I have to get mamaw back in the bed to maintain her airway, then I get mamaw back in the bed. But if mamaw's fine sitting on the floor, where do I leave mamaw? On the floor. And I try to keep whatever it is where it is. Who needs to be, if you're out somewhere, who needs to be the person to move mamaw? The EMT. You don't move them. If you can, you get the physician in the room. If it happens in the hospital, you get the physician in the room so he can see the extremity and he decides what to do with the extremity. He may want to get something under mamaw. You might have mamaw lay down and pick her up with the sheet, but let him see mamaw, if possible, how mamaw is laying where they are. What do we do to the extremity? So we've gotten patient back and they have external, they have the cast on. What are you going to do to the extremity?
Elevate it.
You're going to elevate it. How do I know that the periphery has changed, if the circulation has changed in my periphery? I'm going to do a neurovascular assessment. And the reason I make a big deal about the difference between a neuro assessment, which checks for what? cerebral perfusion, and a neurovascular assessment that checks for peripheral perfusion, is that I've been called out in the middle of the night because one shift, day shift, was supposed to be checking neurovascular assessments on the patient's extremities. What was she going in the room and doing? Neuro assessments. And so when night shift changed, patient's leg was cold. And so, because she actually did the neurovascular assessment, and we got called in the middle of the night to try to save the person's leg. So you have to make sure that if it says neurovascular assessment, you're checking peripheral perfusion. Neuro assessment is checking for cerebral perfusion. So I'm checking for sensation, temperature, color, capillary refill. What's the only way to know if it has changed? I have to check a what? I have to check a baseline. Who needs to be at the bedside when you're checking the baseline? Whoever is handing off to you. And if you're handing off to somebody else, they're in the room, because what are they going to say? It wasn't like that with me. It was fine when I was here. So you have the person stand there and you check it while they're standing there. Because if it changes, the only way to know it's changed is if you have what it was like originally. Because could I have cold fingers? I could have cold fingers. But what's the only way to know that they were cold before and they're still that same temperature now? Baseline. So I go ahead and I sit that hand on the pillow and I elevate it to decrease what? Swelling. Because what's our primary problem? Compartment syndrome. Could I have baby's hand elevated on the pillow? It's broken. It's elevated up on the pillow. Mama is taking care of baby, and she has it 65 degrees in the room. And I have the rest of me covered up. What would this hand feel like? Cold. What would the rest of me feel like? Warm. So what's the only way to know? Do I stop when I get to cold? What do I have to keep on doing? I got to check all the rest of it. If I am 5 years old and you ask me, can you feel me touch your finger right here? What's the answer going to be?
Yep.
I can do it. So what do you need to have the child do?
Look away.
You turn them in the other direction and then you ask them, which finger am I touching? Or tell me when you can feel me touching. Because if you ask a yes or no answer, and depending on what they think the answer is supposed to be, that's what they're going to answer. What are they going to say their fingers feel like if their fingers are going to sleep?
Tingling.
They're going to say, my fingers are tingling. It's going to feel like needles are poking it. Sometimes they'll say, it feels like bees are stinging it. So they may not say the term asleep. They may not say, my fingers feel asleep. So you may have to go with some other type of words. What do I need to, if my hand is exposed and it's cold, what do I need to do to it? Continue assessing it. I'm going to stick it under the covers. I'm going to let it warm up a little bit, and I'm going to come back and check it again once it has warmed up. And then the biggest thing is that I'm comparing it to what? The other extremity. Because is it possible that Mama has a thready DP pulse all the time? But what's she probably going to have? A thready DP pulse on the other side. Not always, but it is possible. What if I'm talking about pulse? What do if the cast is wrapped so that I cannot palpate that pulse? Do I say unable to palpate? What does that mean? It was absent. It means that that pulse in that extremity was absent. So I say unable to palpate due to cast location, and then I explain what.
The capillary.
The rest of it, the capillary refill, the temperature, I go through all the rest of it. What if you stop at one and you call the physician and you say, Billy's hand is really cold. What's he going to say? He's going to ask about the rest of it. So you need to have all that information ready when you call them. Do casts stink? Do they itch? Are they aggravating? So what's your first thing, you're a kid, what's the first thing you're going to do when it starts itching? Stick something down there and start itching. Coat hangers, pens, sometimes they'll lose the item down in the cast. So you try to keep them from sticking things down there. They're going to do it. But just keep, remind them that if they scratch something in there, you can't assess it and you can't take care of it. So it might mean that that cast has to come off and they have to get a new one. So what are some things I can do to relieve itching without sticking something down them? Is cool or heat going to be less itchy? Cool. So keeping the temperature cool in the room. I can get a hair dryer and put it on a cool setting and blow air down the cast. The cool air is going to help it and also dry it out, which will help the itching as well. What medicine could I give? Benadryl. I could give some other type of antihistamine. If they don't like the Benadryl, you could give them some other type of antihistamine. Can I stick Caladryl or calamine down it? Yeah. Can you stick it in a warm tub? I mean, in a cool tub or cool water? You have to make sure that they're doing what to it when the baby takes a bath. They got to make sure that they're covering it with some type of plastic to keep it dry. I'm going to show you external fixator in just a little bit. Who else needs to know about circulation? Caregiver. What are you going to tell them now? If the peripheral circulation decreases and you think that there is compromise to the distal extremity, then you need to make sure that you notify the physician. What are you going to say? If it changes color, if it starts to get numb, you got to use layman terms, because if the baby's hand starts to turn pale, they need to know that they need to let somebody know. Does it have to turn purple to have decreased circulation? No, it can be pale in color. So any kind of color change, they need to make sure that they get somebody's attention. And it may be the child noticing it and notifying the caregiver. This is RICE can be used. A RICE protocol can be used not just for fractures, but anytime there might be inflammation involved or swelling involved. So what are some situations where you might have swelling that you might want to teach this to somebody? A sprain or a strain. It could be that there is swelling due to some type of infection on the extremity. So it could be for lots of different reasons, but this is to treat what? Inflammation and swelling. And the only one that you really need permission for is the ice. I wouldn't put ice on anything without asking the physician first, especially if it's an internal fixation, an internal reduction, because you don't just have the fracture now. What else are you dealing with? Did I say? The surgical area. So if you put ice on a surgical incision, you can compromise the healing to it. So you got to make sure that you get permission for it. Could my compression, could my cast be causing a decrease in my circulation? Yes. What's the only way to know if we truly have decrease in circulation or if it's the cast? You got to take the cast off. So what would I see that would make me think, oh, this cast may need to come off?
The leaking black stuff out the bottom of the cast.
That would be really bad. But we would have a decrease in our peripheral circulation, so we would have an alteration in our neurovascular assessment. So we would notify the physician. So we have a lengthened capillary refill. Our periphery are cold. It's pale. It's tingling. Is it going to hurt if we have a decreased circulation? Yes, the baby's going to complain of pain, and you're not going to be able to what? Relieve it. Nothing you do is going to be able to relieve the pain. Then you're going to think, well, this cast may need to come off. Can you cut the cast off with a band of scissors? What do you need? Cast cutter, which is probably going to come from the emergency room or from the orthopedic floor. Do you wait till the physician gets there and says, I think we might have compartment syndrome and we need to cut the cast off? What are you doing while you're calling him? You get in the cast cutter. So we're taking off our fixator, our cast, so what do you need in its place? You got to have a splint or something to go in its place. So you got to be thinking about all this, because is the physician going to be able to sit there and hold the extremity while you run around and think of something to get? No, you need to have all that stuff at the bedside ready to put it in place, because if we have a fracture, we got to have a reduction, and then we got to also have what? Fixation. You have to have the reduction and the fixation in order for it to heal. And you're taking the fixation away, so you got to put fixation in its place. A lot of physicians have started putting soft casts on for the initial period. So when they're in the hospital and they initially have the fracture, they put a soft cast on. So it's hard, but it is not as hard as the plaster cast is. So you have to be more gentle with mobility, because it is at higher risk for moving the reduction than the plaster cast is. But why would the soft cast be important?
It needs to be adjusted.
It allows and compensates for swelling. So they allow the swelling to occur, and then several days after they have left the hospital, they go in and have the plaster cast put on in the physician's office. So I have a fractured leg. Who are you going to be calling to help me mobilize? Physical therapy. What are they going to have to teach me to do? They're going to have to teach me to walk with my crutches, how to get up without injuring myself. Do you have to have, let's say the doctor forgot to order physical therapy. What do you need to do? You gotta get the order, because can they leave without physical therapy coming to see them? You got to make sure. So that's one of those things you got to check behind them and make sure. Because what are they typically worried about? The bone. They're worried about bone and circulation. So sometimes they'll forget about the physical therapy. They have to see them before they leave the hospital. Are y'all with me? Okay, so this is a green stick fracture, and this is one on an actual x-ray. And there it is. So you can see how it's because the bone's so translucent, it's kind of hard to see. So what might we have to keep getting for a while? Sequential x-rays. So the baby's going to be acting like their leg hurts. They're not going to be wanting to move it very much. They're going to be guarding it. It's going to have some swelling in it. So we suspect a fracture. We're going to treat it as a fracture. But we may not know exactly where that fracture is and what to do with it until the osteoblasts form. So when the osteoblasts form, you're going to have a little line of white right there. And they start forming within like 24 hours, I believe. And then this is a complete fracture right here. So what kind of cast would that baby get? a spica cast. So it's going to come down and immobilize the hip, because what's connected to this femur? The hip. So we got to immobilize the hip as well. So if the hip moves, the top part of that fracture is going to move. So they're going to end up with a spica cast, which I'll show you in just a minute. This is a spica cast. Does he look old enough to use potty? But what's she putting on him? Diaper. Because can he sit on the potty? No. Depending on who puts it on, there is area in the back for elimination, but depending on who puts it on, some are bigger and some are smaller. Why does he have a hole right here? You want to be able to auscultate him, but also it allows for what? Chest expansion, and for his diaphragm to expand, and also to help him eat, because if that was pressing on his belly, he's probably not going to want to eat very much. This is called pedaling. You take soft, sticky fabric. Most of the time it's moleskin. We call it moleskin. It's soft on one side and sticky on the other side. We cut it into strips and then wrap it around the edges of the cast, because what can happen under that cast? Skin breakdown. So what do the parents need to do around those edges every day? Check it. Do a skin assessment. You can do it down here on the edges too. So let's just say it was a leg cast and it was rubbing his feet and rubbing where his knee is. You could pedal that as well. It doesn't have to just be, you can pedal any cast. It doesn't have to be just a spiky cast. Can he walk in that? So he is going to be, can he ambulate or do anything? He's going to be laying just like this. So is he going to be miserable? Is mama going to be miserable? And he's probably going to end up being total care. So if mom and daddy both work, what's that mean? They're going to have to find somebody to stay with them, because is daycare going to take him? Probably not. What could I put under his legs to help support him a little bit? I could put pillows under his legs, especially his little feet are going to be kind of hanging down, and you want to elevate them a little bit so they're not hanging down over it. Yeah.
So I had a cousin, when he was 7, he broke his femur on trampoline, and he had to get on these.
Mm-hmm.
And his didn't have a little hole in the middle. It only went up to like the belly button, but it had a little hole so he could pee.
Mm-hmm.
And because I mean he was way too little for diapers, but they had to pull him around in a wagon. So he did not walk at all. Like it's just.
And a lot of the problem with not diapering, if they make the holes big enough, it may be okay, but urine and feces can drip down and get into the cast. So most people, and it depends on the size of the child too, but most physicians are going to want them to be diapered. So do you put the diaper on if the physician does want them diapered? Where does the diaper go? On top of the cast or under the cast? Under the cast. You shove it under the cast, because if you put it on top, is it doing any good? You need to make sure if they do need diapering, or they do, the physician does want diapering, do you say this is how you do it? What do you do? Return demonstration. I'm going to do this one, and the next one I need to see you show me how to diaper the child. We had a little girl. She had a broken femur, which was suspicious, and she ended up with a spiky cast. She went home with mama and Mamaw, and she came back in with a fever, and they cut the cast off of her. And to make an OR nurse gag is pretty serious. They don't typically get very nauseated at things, and the OR nurses, when they cut it off, were gagging. because she had pee and poop under, going down both legs and all around her hips. Her skin breakdown was so bad she ended up being transferred to her burn unit. So DHS ended up getting called, and that baby was not given back to Mama and Mama, and it was from improper diapering and care of the cast. And then so she was saying it didn't come all the way up. Some of them, if it's just one femur, like if this, and I imagine he probably has a hip issue why his is so high. If it was a femur and this was the only femur, some of them will even have the other leg stop at the hip so that the only thing truly immobilized is the one leg that's fractured. So they may look a little different depending on what the child is. But the care of it's going to be the same. The child's still going to be immobile, and you're still going to have toileting issues, and everybody's going to be miserable. The whole family's going to be miserable. This is a walk-in boot. He may have a fracture that's healing, but what else could he have had, did I say? Internal reduction with internal fixation. That may be support for that extremity. So who do you have to ask to make sure they can weight bear? The physician. You got to get an order for weight bearing. This is an external fixator. It looks like that halo traction. So what's going into my bones? Pins. I'm gonna have, you can see there's a rod right here with some screws. Up here is some wires. So they have internally reduced it and fixated it, but he also has an external fixator as well. So what do I have to do? What do you have to teach family members to do? Pin care. This is just another. So can I walk with that? So what am I probably going to have if it's on my lower extremity? I'm probably going to have a wheelchair because I'm not going to be able to be mobile with that. And are they going to keep me in the hospital for 3 months while it heals? I'm going to go home with it. This little girl, her foot looks deformed, and I can't tell if her foot is that short or if that's the way, but I think the way she's just sitting on the bed, but she may be having some leg lengthening, but that's also an external fixator on her extremity. This is a fasciotomy. So if I'm having a fasciotomy, I'm having an otomy of my fascia. So they're cutting through the skin, through the subcutaneous tissue, through the fascia to the muscle. So the muscle is going to be exposed. And why are they doing this? Because the fascia has become a tourniquet. And what do we call that? Compartment syndrome. We were talking about burns, and you saw the eschar-otomy. The eschar will cause compartment syndrome as well for the same reason. It becomes a tourniquet effect, and at that point you're cutting through the eschar. So you have an otomy of the eschar. This one I have an otomy of my fascia, and the fascia sits on top of the muscle. I've had students always like to ask, are they going to do this at the bedside? I've heard stories about people doing it at the bedside, but when I've had patients that had compartment syndrome, it was more of like an emergency surgery kind of situation. We got consent signed, and we called in the OR team, and the anesthetist came around and talked to the patient and the family and everything. It wasn't like like an ER situation where, you say, grab me a scalpel and they just slice them open. I'm not saying that doesn't happen, but in my experience, that's not what happened. I also don't think they would do that to a child. I don't think they would grab a scalpel and slice a child open. So if they're going to do a fasciotomy at the bedside, what is the physician going to have in order to slice through somebody? Gonna have to have a scalpel. We're gonna have to have something sterile to clean it with. We're gonna need some sterile towels. So while I'm grabbing all this sterile stuff for the physician, what else could I be grabbing? I'm probably gonna need a consent, but I'm gonna need some sedation and some pain medicine, because same thing with the external reduction. I'm going to have to put the patient down quick. Now, if I get all the sterile supplies and I say, can I go get some sedation, what's he probably going to say? I'm like, no, I'm just going to go ahead and do it. I don't have time to wait on you. But if I have it in my hand and I say, here's your sterile stuff, I got some sedation right here, I'm going to give him some so-and-so, what's he probably going to say? Okay. But, thanks. But if they have to wait on you, for whatever reason, it makes them feel like it's like 400 years, especially in an emergency situation. So if you know you need something, just go ahead and grab it and have it there with you. They'll be more likely to say okay to it if you already have it there. But that's not the situation I've ever been in. We had a snake bite and an animal bite that developed compartment syndrome. And it was just like, okay, they have compartment syndrome. We need to go to the OR. It wasn't like a grab me a scalpel kind of situation. What time is it? Let me, if I can get through these real quick, I'll let y'all go instead of having a break. Is that okay? Okay. So, these, the congenital limb defects and the Osgood-Schlattler are not in your book, but they're in your syllabus. So I feel like I need to give you the information. I posted the information from another book on Canvas. I think I called it handout or something. Yeah. But that's this information. So you need to be aware of it. Hint, hint. So congenital limb defects is a defect of a limb that they're born with. It typically has something to do with the position of the baby in utero. It can have something to do with some different types of disease processes and what the parent was exposed to. But a lot of the time it is due to position of the baby in utero. And sometimes they don't know what happened to it. So there are some different types. They're kind of self-explanatory, except for this one, the congenital constriction band. There's fibers that are floating around in the amniotic fluid, and sometimes those fibers can wrap around an extremity and decrease circulation to the extremity, and the extremity doesn't grow properly. And I have a picture of that in just a minute. What they do for the defect really depends on how well the child can use that extremity. Sometimes they'll remove the extremity if it's not useful and allow for a prosthesis. But if I have a finger and a thumb, even if I just had the thumb, I can learn to do a lot of things. Especially if the child's born with it, they'll learn to adapt themselves to whatever. Like the baby who his feet were completely, his legs were folded up and his feet turned upward. I mean, he got around just fine. He'd walk and he'd stop. He could scoot around with one hand. He'd pick himself up with one hand and scoot himself. I mean, he could do just about anything. We'll see kids and adults who use their feet instead of their hands. They'll feed themselves. They'll stop and scratch their nose with their foot, and they'll brush their hair and brush their teeth, put their makeup on, because they're born without any hands. So it really just depends. Sometimes if they can make for a prosthesis, though, they'll go ahead and remove the extremity to allow for a prosthesis. I may need what kind of therapy? Occupational therapy. So physical therapy, they may get physical therapy and occupational therapy. So remember that physical therapy strengthens the body. Occupational therapy teaches them how to do things in a different way. This is the constriction band. It's only on one finger right now, but I think it was wrapped around all of those fingers, and as the fingers grew and the hand got bigger, it ended up only being wrapped around one. But could I use that finger and that thumb? So I may be just fine. So the likelihood of them removing that hand is probably unlikely. That child's going to probably live just a normal, happy life. This is an undergrowth. They probably would remove what's left of that foot to make a stump and give that baby a prosthesis. Because could I run and jump like this? No. But could I run and jump with a prosthesis? So I would be more likely to have a more normal life with a prosthesis than with my extremity. This is a duplicate. I don't know, one of these arms, this arm looks like it might be functional, and this one looks like it's the extra one. So if they can figure out which one's functional, they'll leave the functional one and take the non-functional one off. If both of them are unfunctional, they'll remove both of them and make way for a prosthesis. This is, and I can't say the name of it right now, paradactyly. Forgive me for not knowing the name of it. This is a type of not separating, so there may be fingers under there and there may not be. They can do surgery to separate and make the rest of the fingers, but what has to be under there? The bones have to be there and they have to be functional. So could that child, let's say that their bones are not under there. There's only one set of bones and not 4 sets of bones. Could I live a normal life like that? Yes. So I could learn to adapt just fine. We had a friend in high school that both of his hands looked exactly like this and his feet were that way. He was just fine that way. But there are some people, if the bones are there, will separate the bones, and then they need physical therapy and occupational therapy to help them learn how to use it. Osgood Schattler. This is a separation of the tendon away from the knee, it's right under the knee. It's the tendon that connects the knee to the tibia, and it tears away from the tibia, not away from the knee. I started to say it wrong. So if my tendon is tearing away from the bone, is that going to hurt? So once again, I could have a partial separation of the tendon, or I could have a complete separation of the tendon. My ability to ambulate is going to be based on the severity of the tearing. So if my tendon is tearing away, what do you think the primary intervention is going to be? Immobilize my leg, specifically my knee, because anytime I bend my knee, what's going to happen to that tendon? It's going to tear more. So they're going to put a knee brace on there and prevent me from bending my knee. It can happen unilaterally or bilaterally. We had a student that had it, and he had it in both legs, both knees, almost simultaneously. He played soccer, and he was playing soccer one day, and it ended up being a really long game, and they tore, and they kept tearing, so it kept getting worse and worse and worse. So why would 11 to 14-year-old males be predominantly at risk for it? They're more active typically than girls. Not to say that a girl couldn't get it, but they also have more extreme growth spurts around that age. So the growth spurt, why would the growth spurt affect my tendon? It's going to, they do not grow as fast as the bone, and it puts stress on the tendon. So if the tendon's stressed and I'm running around, jumping around, the stress can tear the tendon. They will have to wear the brace for several weeks, and then after the brace is allowed to come off, they'll still have limitations to their activity. So what if I have swelling? What kind of medicines am I going to need? NSAIDs. Probably gonna need some pain medicine. Ice and elevation would help it. And their activity is going to be limited for 3 months after they come out of the brace. Y'all have any questions? Let me show you a picture. So this is the knee, and this is where the tendon is pulling away from the tibia. So it's going to be swollen and painful, limited range of motion and limping. Don't forget to look at, there's weird stuff. You're only responsible for the disease processes that I put on the PowerPoint. So you have to get the information off of Canvas for those last two. Make sure you read it and read everything in the book that has to do with those disease processes.